Good evening, everybody. Welcome to this evening episode of Pathology Understanding for residents and students. And today we have a special talk. But before we go into this, let me share a few things with you. First is please keep your mic muted. Please keep your camera off. And please do not share your screen. When you log in, please press join now and don't press present now. Welcome to this evening. We welcome Dr. Murali as well as Dr. Santosh. Please, Dr. Santosh, please take over and moderate the session. Thank you so much.
Good evening, everyone. Am I audible?
Yes,
Yeah,
Santosh.
Yes, Santosh. Yes.
Yes. Okay. Yeah. Thank you, Dr. Nadeem, for inviting me for this session. And I think Dr. Murali Varma needs no introduction at all. He has been to India several times, and we all know that he's a great debater, and he has got a long list of achievements to his credit. A few of them I will highlight as I've been interested with this responsibility. Sir is now currently working as consultant histopathologist at University of Hospital of Wales in Cardiff. Cardiff is a beautiful place, and I had the opportunity to visit him and learn from him a few years back. He did his MD from PGI Chandigarh, and he had the honor of having the Kataria Memorial Gold Medal, which is given to only one resident in whole of PGI, including all specialities. So that's a great achievement he had. He is currently the chairman of British Association of Urologic Pathologists. He is chairman working group of IACUP Consensus Conference in Prostate Cancer Grading. He is member of the steering group in European Network of Uropathology. He has several publications to his credit in very, very reputed journals like Histopathology, Human Pathology, BMJ, Diagnostic Histopathology, Workers Archives, and he's on several editorial boards. He has several invited publications, which is a very, very great honor. And he has special interest in prostate cancer. And I have heard Dr. Varma several times, and he can put forth his points very, very well. And he will instill things in our minds today, I'm very sure, and it will leave us with a lot of thoughts about prostate cancer. So with that, I hand over the mic to you, Varma sir. Please welcome people from India waiting to listen to you.
Thanks, Santosh. Right, Nadeem, if I can, so if I share my screen, is it? Or are you going to share it from there?
No, sir, you share your screen.
Yeah, so I go from mine. Yeah, so give me a second. Just present now. Present a window. And that's the one.
Your whole screen.
Yeah, perfect. Yeah. Okay, thanks, Santosh, for the kind words. You make me feel even older than I am. It's always a pleasure to teach, and it's always a pleasure to talk to Indian pathologists for multiple reasons. I think it's 7:30 in the evening there, and yet you guys have the enthusiasm to take the time off to listen to what I've got to say. I'm very grateful for that. For the trainees, again, I think you guys are, I think you all have got some very good teachers in India. So so there are times when I feel a little embarrassed to teach you all because you'll have so many good teachers there. I trained in PGI, where we had our teachers like B.N. Datta, A.K. Banerjee, Shobha Sehgal, Subhash Gupta. I could go on and on and on. They were wonderful teachers, and it is a pleasure for me to contribute a bit from my side. I'll start with this quote, which is one of my favorite quotes. It's from Socrates. I cannot teach anybody anything. I can only make them think. And that is what I try to do. So if you're expecting to learn Gleason grading from this lecture, I think you'll be disappointed. This is not intended to be an instruction manual to tell you how to grade prostate cancer. What I'm trying to get you to do is to understand prostate cancer. Now, Dr. Nadeem is to be congratulated for this excellent set of program that he has developed. The pathology understanding for residents and students. So let me start off by making a few general comments for the trainees. When I was a trainee, things were very different. We had very little information. I remember doing my cytopathology senior residency, and we had only 2 monograms by Jajisek, and that was the whole of our cytology literature. After that, it was Acta Cytologica. For you today, it is the reverse. You all have got too much information. The amount of papers that you have out there, the number of lectures, webinars, you are bombarded with information. So for you, we had to look for information. For you, information finds you. And so it becomes harder for you to decide what is important, what isn't important. You will get divergent views. And you have to be able to know which one to accept, which one to doubt. And so I think in the Pursue program, the key word is understanding. Because that is the key. There is a difference between learning and understanding. Learning the rules is simple, but that won't get you anywhere. If you understand the rules, you can then apply it to different situations and actually makes life a lot easier. Again, another of my favorite quotes is from Three Idiots. I won't try out my Hindi because I think it's long gone. But basically, the circus lion is well trained, not well educated. And the key for the trainees is to get educated and not just trained. So to understand what you're doing. My other favorite quote is from Shane Warne. I think this was Shane Warne commenting on Monty Panesar. And I think it was a bit of a mean quote. It was not, I think it was a little cruel, but he commented that Monty Panesar hasn't played 33 tests. He's played one test 33 times. And I think this is a very important message for the trainees. Sometimes trainees think that they will learn more by looking at more slides or more cases or by reading more papers or attending more lectures. No, you don't. It is not the number of lectures you attend or the number of books you read, but it's how you read it and what you take. So you can attend only one lecture and learn a lot, or you could attend 33 lectures and learn less than what you would have learned with one. So the key thing is to understand try and understand the topic other than just learn what the rules are. So again, the point, my title is Gleason Grading, a Pragmatic Approach. So I am not trying to teach you Gleason Grading. I'm trying to show you, to explain to you a different way of looking at Gleason Grading. Prostate cancer grading is one of the most important prognostic parameters in prostate cancer. It's a critical component of all management. So a lot of management decisions are based on prostate cancer grade. And when it comes to grading, the Gleason grading system is a globally established system since the 1980s. So it's been around for a long time, but let's look at the timeline. So you had the initial report in 1966, the final report in 1974. So in 1974, we had the complete Gleason grading system laid out. In 2002, the WHO included the Gleason grading in their manual, and that was not on its own, but with other grading systems. In the 2004 edition, the WHO adopted only the Gleason grading system and abandoned all the other grading systems. So Gleason was not the only grading system. There were several other grading systems, but Gleason was chosen. Then so you can see there was a big gap from 1974 to 2002, nothing changed. In 2004, the WHO accepted Gleason as a sole grading system, and then everything changed. In 2005, we had the international consensus of the ISUP meeting, which essentially made very, very major changes in the Gleason grading system. about 10 years later or 9 years later, we had another consensus conference in Chicago, where again we made more changes in the grading system. So there was from 74 to 2005, the Gleason grading system was stable. After that, in the next 9 years, we changed the grading system, and now in 2019, which is only 5 years later, there have been two separate. As you're probably aware, the international uropathology expert groups have divided into two different societies: the Genitourinary Pathology Society, or GUPS, and the International Society of Urologic Pathology, ISOP, and both of them have come up with their own independent papers on Gleason grading. So this is only another about 5 years from the previous grading system. So you can see how soon and the short intervals in which Gleason grading is changing, and it's changing rapidly, and it's extremely difficult for everyone to keep on top of it. So let's start from the very beginning. So let's ask the question, why Gleason? There were many other grading systems. Why did we adopt the Gleason grading system and not the others? In 1978, the American Cancer Society compared Gleason, Morphology, Gaeta, and the Mayo grading systems for prostate cancer and recommended Gleason because it was definable, simple, reproducible, and had compelling clinical relevance. So this is what they said. When I look at that, the word that jumps out is simple, because whatever else it is, the Gleason grading system that we have today is not simple. There are at least two excellent textbooks on the Gleason grading system, and there are more. These are the first two textbooks, and subsequently there have been more books published on the Gleason grading system. Are you aware of any grading system on breast cancer, colon cancer, lung cancer? No. It's only the Gleason grading system, which is so complicated that we can write whole books on the grading system. I would argue that the grading system is too complicated. It is, what we've got to remember is that science is important. We've got to get things scientifically correct, but it has to be practical, because at the end of the day, all grading systems are going to be applied by general pathologists. The majority of prostate biopsies globally are not reported by super specialty experts. They are by ordinary jobbing general pathologists, and then obviously you got all your trainees, etc., who are trying to learn breast pathology, gynae pathology, GU pathology, etc., etc. And if you make a system so complicated that nobody can understand it, it's meaningless. Let me show you some examples. So you've got the GUPS guidelines. So you've got, in a prostatectomy specimen, if you've got less than 5% pattern 5, should that be included in the Gleason score, or should that be excluded from the Gleason score? So if you've got 4 plus 3 plus and less than 5%, should that be reported as 4 plus 3 with minor or tertiary pattern 5, or as 4 plus 5 equals 9? The answer to this question is extremely complicated, because the answer is yes and no. If you got 4 plus 3 with less than 5% pattern 5, then you exclude the minor pattern and call it 4 plus 3. If it is 4 plus 4 with less than 5% pattern 5, then you include the minor pattern and report it as 4 plus 5. Now, this may be scientifically correct. I would question it, the science behind it. But even if it is scientifically correct, can you reasonably expect jobbing general pathologists who are trying to keep on top of gynae, breast, and everything else to be able to remember such minutiae? And then you got the grading system, the variation in the grading system. We know that the reproducibility of Gleason grading is not great. It's moderate at very best. It's probably, in most cases, I think it's less than that. Now, when we have variations in grading, there are two different reasons for that. One is interpretation. Now, when you have a morphological continuum, that's inevitable. You can't help it because where do you draw a line? This is drawing a line in the sand. It's an artificial line in a clinical continuum, in a morphological continuum. You cannot, there is no line there. It's an artificial line that we are drawing. So this variation is inevitable. It's there with colon, it's there with breast, it's there with everything we do in pathology, right from diagnosis. You will have variations in interpretation because histopathology is a subjective specialty, and we can live with that. That's not a problem. The problem is when we have different rules advocated by different expert groups. Now that makes life impossible. How is a general pathologist expected to keep on top of when one expert group says X and the other expert group says Y? Here's an example for you. So we've got these two papers now on Gleason grading, the GUPS and the ISO papers. So what do they say? So we'll talk about this a little later. But you got the intraductal component of invasive prostate cancer. So you've got invasive prostate cancer, and then you've got IDCP. I'll talk to you later about what IDCP is. But the point here is, GUPS recommends that the IDCP component should not be included. ISOP recommends it should be included. So which means if you've got 3 plus 4 equals 7 with comedonecrosis IDCP, ISOP recommends reporting it as 3 plus 5 equals 8, while GUPS experts would report that as 3 plus 4 equals 7. I'm not going to go into who is right and who is wrong. But the point is, this is not a viable situation for pathologists. We can't have two different groups, in which case we cannot compare anything. We cannot compare data from India with UK or even within the US. If you got some people following the ISOP rules, some people following the GUPS rules, so that exactly the same case would have a totally different Gleason score because we are following different rules. Similarly, the minor pattern, less than 5% pattern 4 in a radical prostatectomy. So if you got 3 plus 3 with less than 5% pattern 4, ISOP would call it 3 plus 3 equals 6. GUPS would recommend calling it 3 plus 4 equals 7, less than 5% pattern 4. So you got the same case would be reported as Gleason 6 or Gleason 7, depending on which rules you are following. I cannot do a Marlon Brando imitation. I wish I could, but as the Godfather said, how did things ever get so far? How did we get into a situation we've got this sort of confusion in uropathology? And more important, now that we are in here, what are we supposed to do? How do we sort out this mess? We are in a mess. Gleason grading, there is no other word for it. It's an absolute mess. It's what they call a dog's breakfast or a pig's breakfast. So essentially what I'm going to outline to you is one way of getting out of this mess. And that is by not focusing just on the science and the accuracy, but by trying to actually understand what we are trying to do. Now for the trainees, I can't emphasize too much that you have to keep reminding yourself that you are a doctor. Histopathologists, we are not scientists, we are not educators, we are primarily clinicians. The only difference is my clinic is my office, and very often I may not see the whole patient, I may only see a bit of the patient, but I am still a doctor. I am still trying to treat this patient. I am not trying to just come up with scientific data. It's not a basic science, it's a clinical science. And I think you've got to keep reminding yourself that about everything that you do, what is it for? Now, this is a paper that I recently published in Diagnostic Histopathology. So if you want to know the details of what I'm talking to you today, I would recommend that you go through this paper. I do not have the time to go through everything. I'm just going to go through some of the outlines of it. I would be shocked if you understand everything that I tell you today, or you remember everything that I tell you today. You can't. But what I hope is you will get the gist of it. that you will get the essence of what I'm trying to tell you, and then you can go back to this paper and read it at your leisure and get a better idea of what I'm trying to tell you. So before we talk about Gleason grading, as I said, let's think clinically. Let's think less about the specimen and think more about the patient. So why are we grading prostate cancer? So in radical prostatectomies and in needle biopsies. In radical prostatectomies, the rules are extremely complicated. I showed you some examples, like the one I just showed you here with minor pattern 5. All I can say is I'm supposed to be an expert in prostate pathology. I have to open these books or these review papers to know who said what where for all these minutiae. If I have to do that, the general pathologist has no chance, absolutely none at all. And the point here is it important? Now, why are we reporting all these data in radical prostatectomies? For prognostication. Why are we prognosticating patients? To know whether to treat them, whether to give them adjuvant therapy or not. Now, if you compare breast, colon, and all other tumors, the only way you can identify who is going, when they get a recurrence, is when that recurrence becomes clinically or radiologically apparent. So until the patient gets some clinical symptoms of the metastasis or the tumor is visible on radiology, till then you cannot see the metastasis. So which is why you're looking at the histopathology to predict micrometastasis. So you are trying to identify patients who already have micrometastasis so that you can give them adjuvant chemotherapy. Right? So when you give chemotherapy for patients with lymph node metastasis or for breast cancer, you are not treating the lymph node mets. The lymph nodes have already been taken out when you've done the lymph node dissection. You are treating the micrometastasis. So you are using the pathology parameters of the grade, stage, etc., to predict which patient has micrometastasis so that you can treat them before that micrometastasis becomes clinically and radiologically apparent. And that makes a lot of sense. But prostate is different. And the difference is because of PSA. So after prostatectomy, the clinicians have the option of following the patient's serum PSA. PSA is not a great tool for diagnosis, but it's a wonderful tool for monitoring patients after prostatectomy, provided the prostatectomy has been done properly and that you have removed all of the prostate, that you have not left part of the prostate in there. If the margins are negative, the benign prostate has been completely removed, then PSA is an excellent tool for predicting as to which patients are likely to get into trouble. And so serum PSA then identifies recurrence long before clinical and radiological evidence of metastasis. So the clinicians don't need us. They don't need us to tell them what the grade of the tumor is. They don't need the pathology to identify patients. If anything, we are already over-treating patients. On serum PSA may be too sensitive. And there's a fair bit of evidence out there that biochemical recurrence does not equate to survival. So patients who have biochemical recurrence, some of them, it may not actually affect their survival. So that endpoint may be faulty. So we may already be over-treating people on the basis of biochemical recurrence because of PSA failure. By using adjuvant, by Gleason grade and the stage and all the other things and giving adjuvant therapy, we might be harming even more people. Recently, there was a trial, a randomized trial, where they randomized patients based on pathology, the adverse findings, whether to give adjuvant therapy or not to give adjuvant therapy, which reported late last year. And what they found, these are still preliminary findings, but adjuvant radiotherapy did not improve the biochemical progression-free survival or time to further hormonal therapy, while it significantly increased urinary and bowel morbidity. The radical trial supports PSA follow-up and salvage therapy. Salvage therapy means giving adjuvant therapy only if the PSA starts rising, rather than giving adjuvant therapy based on pathology findings. So here you've got evidence here that pathology findings may not be relevant in radical prostatectomies. But unfortunately, nobody told the pathologists that. The pathologists are still going around. We are making radical prostatectomy reporting a lot of work and extremely complicated. Now, I'm not saying that don't grade tumors at all in a radical prostatectomy. But if you're going to give adjuvant therapy based on the Gleason grade, you would want something obvious. It has to be obviously bad Gleason score, obviously a 5+5 tumor or 4+4 tumor, a very obvious one. Not these borderline with less than 5% pattern 4 or less than 5% pattern 5. The ones that we fuss about, argue about, have a lot of meetings and whatever, and a lot of hot air, that is a waste of time. And that actually does not benefit patients. So we are making things complicated with very little clinical utility. So in my opinion, prostatectomy grading is far too complicated and has limited clinical utility. Okay, but that's the more important is the biopsies. So most of the treatment management decisions are on biopsies, and the Gleason score in biopsies often determines the management. So maybe we have to get it exactly right, because the Gleason score might decide whether this patient goes for follow-up or has a radical prostatectomy with the risk of incontinence, impotence, etc., etc. But there's a problem here too. Yes, we can all be scientifically very, very accurate and try to draw perfect lines on that tiny bit of tissue that they have taken out and given us. But what's the use of that? What we are trying to do is I am not trying to prognosticate the biopsy. I am trying to prognosticate the patient. And when it comes to prognosticating the patient, you've got the sampling error of the biopsy technique. So however wonderful the pathologist is, the rate limiting factor or the limiting factor is the sampling error. And so whatever we do is only a rough estimate of the true tumor grade. So essentially, it's the blind man and the elephant. So it depends on which bit of the elephant or the tumor that we happen to sample, and we'll say that it's either good, intermediate, or bad. Now here are a couple of very large series. These are series looking at radical prostatectomy specimens and comparing the Gleason score in the biopsy with the Gleason score in the corresponding radical prostatectomies. Now these are the one on the right of the screen for me is from Johns Hopkins, and the one on the left is from Karolinska and the Swedish group. The Hopkins group has about 10,000 radical prostatectomies. The Karolinska group has about 16,000 radical prostatectomies. So these are very, very large series with very big names. So you got Jonathan Epstein here, you got Lars Egevad, you got big names here. So these are not pathologists who have problems grading. They know Gleason grading pretty good. So how good is it? So when the biopsy grade is 4+4 = 8, how good is it at predicting what is the radical prostatectomy grade? In about 50% of cases, the biopsy overgrades. So the radical prostatectomy grade is less. Okay, that's inevitable. Okay, so if I report as 4+4 = 8, there was some pattern 3. There's a little bit of pattern 3 which was missed. But that's not what it is. In 20% of the cases, in the radical prostatectomy, there were primary pattern 3. So we had 4+4 on the biopsy, and it was either 3+3 or 3+4 on the radical prostatectomy. Now that is huge. That is a very significant difference. So again, there are other series showing the same thing. The paper suggesting here that most Gleason 8 biopsies are downgraded. So should 4 plus 4 be called 7 rather than 8? And it's not just 4 plus 4 equals 8. If you look at Gleason score 3 plus 4 equals 7, about 20% of them are upgraded. 4 plus 3 equals 7, about 40% of them are downgraded. So which means the Gleason score in the biopsy is only a guesstimate. It's a rough estimate of the true Gleason grade. So all this business about getting perfect reproducibility and perfect accuracy and precision is impossible. You can't do it. We can pretend, but we can't do it. So all we are doing in a needle biopsy is saying where this grade is. This patient's grade is somewhere in this area, or is it somewhere in the middle, or is it somewhere in the bad one? And even there, with sampling errors, some of that what we say is here, there might be a 5 plus 5 tumor there which is not sampled by the biopsy. So even that will not be perfect. So perfect precision is simply not possible. So I hope I've convinced you that we cannot do perfect precision. So perfect Gleason grading. So I think a lot of the reason I emphasize this is that a lot of pathologists feel very insecure. They feel there's something wrong with them. They feel that they are inadequate because they are not able to get the right Gleason score. Because they report a Gleason score, it goes to the expert and the expert changes the Gleason score. And they feel that there's something wrong with them. No, there's nothing wrong with you. The problem is the nature of the beast. The technique is intrinsically flawed. But more important than that, what I would like the trainees to understand right at this stage is that perfect precision is not necessary. We don't need it for clinical practice. So what I'm going to talk about in this lecture are some of the basic concepts of Gleason grading. I'm not going to talk about the details. I'm not going to talk about when you call it pattern 3 and when you call it pattern 4. You can read that in the books, but much more important is to get an understanding as to what is the meaning of pattern 3. When I say pattern 3, when I say pattern 4, what does it really mean? And then how do I report it? When I have got multiple scores which are showing different Gleason scores, which score should I give? Now, in no other organ, if I get 3 biopsies from 3 bits of tissue from a colonic tumor, I don't give separate grades for those 3 bits of colonic tissue. Or if they were to take 3 cores from a breast tumor, I don't give separate. But in the prostate, that is what is recommended. So we'll discuss that. I'll discuss this very complicated issue of intraductal carcinoma of the prostate. And finally, a few words about the new grading system for prostate cancer. Santosh, at this stage, I'm happy to take a couple of questions. Santosh, while you do that, I'm just going to get a glass of water.
Sure, sir. Sure. So, any questions from the delegates audience?
Sorry, Santosh, I'm back here.
Yeah, so Vishal has asked a question. Can we retrace our steps and can we replace it with some routine grading like well differentiated, moderate, and poorly differentiated?
That is essentially what we are doing. So we'll come back. So I think at the end of the lecture, Vishal, I'll explain to you that is exactly what we are doing. So we do all these fine details of grading, but then we group these scores together into low grade, intermediate grade, high grade. So pathologists tend to split. Clinicians and oncologists will lump. Okay, so we'll come to that. It's a very valid point. But I think the point I would make is that we can, even with this grading system, we can live with it, provided we understand what we're doing and make it simpler. Santosh, is there any other question?
Yeah. Dr. Paramita asks, do you prefer ISUP to GUPS?
Well, put it this way. Sorry, I've gone out of this. Yeah. It's a very political thing. Okay, I'm not. Those who know me know that I'm entirely apolitical. I'm part of the ISUP paper. So I was the chairman of the working group for the introductory carcinoma in the ISUP consensus conference. So I have got a vested, I've got a conflict of interest here because I am part of the ISUP group. I will again explain to you what the differences are between ISUP and GUPS. I think the differences are exaggerated. I don't think there's a huge difference between the two recommendations. I think we are playing with minutiae. We are playing with words. Paramita, I hope at the end of this, I will be able to convince you that actually it's a much ado about nothing. Okay, I'm going to move on and we will take some of these questions at the end again and see whether I have managed to convince you. Now, borderline Gleason score, Gleason 6 versus Gleason 7. Now, again, this is another thing I've got to, whenever I talk to pathologists in India or in other countries, I have to make it very clear, is that everything I say is biased by my clinical practice. So the sort of cases that I see are different from the sort of cases you see. So my problems will be different from your problems, and so my solutions will necessarily be different from your solutions. And you have got to understand that. So sometimes the danger is when pathologists in India blindly follow experts from UK or US, that may not be applicable to your practice. Similarly, we have the same problem in the UK. Sometimes we blindly follow recommendations from other countries, which make very good sense for their practice. So some of these recommendations have got to do with financial implications, billing, which is not an issue in the NHS. So I'll give you one example of this, which is not from the prostate, which is from gynae. The weight of the uterus has no clinical significance whatsoever. So if you've got a fibroid uterus, what is the weight of the fibroid uterus has no meaning. But it's a mandatory data item in many jurisdictions. The reason for that is in the United States, the surgeon's remuneration, the reimbursement, the money that he gets for doing a hysterectomy depends on the weight of the uterus. So if the weight of the uterus is more than 250 grams, he is paid more than if it is less than 250 grams. Now that's an entirely reasonable thing to do because they needed some way to decide as to which is a simple hysterectomy and which is a more complicated hysterectomy, which will take more time and needs more money, should be paid more. But the problem comes when we follow that in the UK, where we've got the NHS. I'm not billing anybody, nobody's paying me. But similarly, it's the same thing with these things, with prostate, etc. So Gleason 6 versus Gleason 7 is a major issue in the UK and in the West, where we've got a lot of patients presenting with early prostate cancer. And the question is, should they have surveillance or radical therapy, either prostatectomy or radiotherapy? In contrast to India, where you predominantly get patients presenting with advanced disease. Now, this one can drastically change the patient's life. You're talking about whether to do a major surgery on this man, which will have long-term implications. And that decision is often based on whether it is Gleason 6 or Gleason 7. So if it's Gleason 6, it is surveillance. If it's Gleason 7, radical therapy. But we know there is significant inter-observer variation even among experts. And this causes a lot of anxiety and angst because you get cases which have been reported as Gleason 6, gets reviewed somewhere else and becomes Gleason 7. Or it's reported as Gleason 7, gets reviewed, becomes Gleason 6. And everybody is upset. The patient is confused, the urologist is confused, the reporting pathologist is confused, everybody is upset. And the point I would like to make is often it's unnecessary. Because we are looking for precision. So we are looking at, is this borderline case? I'm not talking about the obvious Gleason 6 and the obvious Gleason 7. The obvious Gleason 6 and the obvious Gleason 7 are different, and you need to distinguish between the two. But my first year training, after about 3 months in histopathology, can confidently say it can diagnose an obvious Gleason 4 and an obvious Gleason 3. 3 months of training is ample. After that, it's all about those borderline cases. And in those borderline cases, does it really matter? And what I will try and explain to you is that in those cases, in these borderline cases, precision is less important, provided the pathologist communicates the information properly and the clinician interprets the conveyed information properly. And unfortunately, both of these often does not happen. So this is a paper we recently published in Workhouse, essentially making the plea that we may pay a lot of lip service for personalized medicine. But if you want personalized medicine, you need personalized histopathology, not one-size-fits-all reporting. And that is the crux of the problem, is that there is a communication gap here between the pathologists and the surgeons. Surgeons view radiology. Surgeons would never look at the radiology reports on its own. They would look at the CT scan or the MRI and the radiologist report. But they don't do histology. If you see a surgeon at a microscope, he is doing a radical prostatectomy. They do not need to be able to interpret histology. So I show this to when I do some lectures for the surgical trainees, and I show this one and ask them, what grade is this? And they often tell me it's Gleason pattern 3. And then I tell them, no, it isn't, because it's breast cancer. It's not prostate cancer. You can see the fat in there. So clinicians don't need to know whether this is prostate cancer or this is breast cancer or what pattern 3 looks like or what pattern 4 looks like. But they do need to know what does pattern 3 mean. So when I say cribriform, they don't need to know what cribriform looks like, but they do need to know what that implication of the word cribriform is. And that is critical. Unfortunately, there is a huge communication gap here because they don't look at the histology here, and they are dependent entirely on what we tell them. And so our reports must bridge this communication gap. So precision becomes less important if we communicate it properly. So we've got, then again, what people come back and tell us, show us these wonderful Kaplan-Meier graphs and say, look at this. Gleason 6 behaves very differently from Gleason 7. The survival of curves are very different. No. What this tells you is that these Kaplan-Meier graphs tells you that an obvious Gleason 6 has a different outcome from an obvious Gleason 7. That borderline case, the one that you're worrying about, the one that on Monday I would call it Gleason 6, and on Tuesday I would call it Gleason 7, those cases would be distributed haphazardly between Gleason 6 and Gleason 7. So they would cancel each other out. So all these graphs are telling you is that the obvious 6 is different from an obvious 7. And so in these, when you're looking at groups of patients for patient cohorts, inter-observer reproducibility is not important. And in these groups, fewer tiers are better. So because the reason for that is if you've got fewer categories, then you have got more patients in each category and you can do your statistics. So this is one of the basic problems we have. Academics, like me, we like fewer groups because it makes my job easier for research. I can get my p-values, I can do my statistics. If I make 20 groups, I've got very few patients in each groups, and then it's very difficult for me to show statistical significance. But for individual patients, the requirements are entirely different. What you have here is a biological continuum. And in that, you got arbitrary lines that we are drawing. And in this situation, inter-observer variation is critical because that's going to decide whether this patient gets a prostatectomy or no prostatectomy. And in this situation, the more categories you have, the better stratification you have, the better. This thought I will expand next week. So next on Monday, when I talk about bladder cancer grading, we'll talk about this in more detail because that's where it's even more relevant. So what you have in Gleason score, now I think I don't need to tell this to pathologists. Pathologists are very well aware that what we have here is a morphological continuum. So by and large, Gleason 6, 7, and 8 is a morphological continuum, and in which we are drawing lines. Not everything. So for example, comedonecrosis or no comedonecrosis, that is not a morphological continuum. But when you get glandular fusion, you get increasing complexity of the proliferation, and then Gleason 6 or pattern 3 will become pattern 4. But this is similar to PSA. So when you've got this continuum, like in PSA, you got less than 10 is low risk, 10 to 20 is more intermediate risk, more than 20 is high risk. So is a PSA of 9 and PSA of 10, is the patient going to behave differently? Of course not. But one would be low risk, the other would be intermediate risk. So these cutoffs are entirely arbitrary as to where you draw these cutoffs. And the one that pathologists have to remember is that it's not just a morphological continuum. It's also a biological continuum. So as the grade gets worse, the risk of extraprostatic extension, of metastasis, of death becomes greater. But this is a continuum. There is no. So next time a urologist asks you, is this Gleason 6 or Gleason 7? It will be entirely reasonable for the pathologist to turn around and say, what is the minimum risk of EPE which you would want for Gleason 7? So do you want that when I say Gleason 7, it's at least 5% risk of EPE, 7% risk, 9% risk, 20% risk? There is no answer. So the reason is because it's a continuum with arbitrary cutoffs. There is no cutoff there. So at what risk of EPE should these cutoffs be? There isn't an answer. And that's why you can never draw a definite line anywhere. A good Gleason 7, so a patient in this continuum who is over here is going to behave exactly the same as here. And so, more important, it's entirely reasonable to treat this patient as a Gleason 6, and it's entirely reasonable to treat this patient as a Gleason 7, because there is no difference between these two. This is an arbitrary line that we have drawn in here. And this concept is extremely important. This is not just about Gleason grading. This is about pathology in general, prognostication in medicine. When you're talking about continuums, in the borderline ones, as pathologists, we feel extremely guilty. Did I get this borderline case exactly right? Because if I called it Gleason 7, this man is going to have a radical prostatectomy all because of me, because I called it 7. Or if I called it 6, he's not going to have a prostatectomy because I called it 6, and he might come back with a metastasis tomorrow. And it's going to be my fault. No, because it's a continuum here. So it's these two patients are biologically, they are no different from each other. Now again, when I explain this to clinicians, I speak their language. So I talk about hypertension. So you've got in hypertension, if you take the cutoff here, as 140 is hypertensive, 139 is pre-hypertensive. So if you got somebody with a blood pressure of 119, that's normal, no treatment. 159, definitely a bad stage 1 hypertension, needs treatment. But the ones in between, whether if it's a bad pre-hypertension or a good stage 1 hypertension, it depends. If you've got other risk factors, you may treat. If you don't have other risk factors, you won't treat. So you make a judgment call in the borderline cases. It's the same thing with the grade. So the distinction is biologically insignificant because it's a clinical continuum. The patient with a bad 7, a bad 6, and a good 7 will not behave differently. But clinically, they're entirely different. It's clinically very, very significant. So the question then comes, how should we report these borderline Gleason scores? So again, if we take a step back and think, why do we struggle? So why do we struggle with Gleason grading, with these borderline ones? And the reason we struggle is because we are doing it wrong. We are basically approaching it wrong. Grade is a morphological and biological continuum. So if we compare that with stage, so RCC stage. So you got the T stage with a 7 centimeter cutoff. So up to 7 centimeter, it is PT1. More than 7 centimeter, it is PT2. But would you report a renal cancer as PT2 and PT1? Of course not. You would report the dimension in millimeters. You would not just report the stage. But grade, which is also a continuum, we don't report it. We report it as if it is a discrete variable. So we report this continuous variable as if it is a discrete variable of either it is Gleason 6 or it is Gleason 7. Sorry. Yeah. So when you got a report of Gleason 7, a tumor at this end of the spectrum of Gleason 7 is very, very different from a Gleason 6 tumor. But a tumor at this end of Gleason 7 is no different from a Gleason 6. Similarly, a tumor at this end of Gleason 6 is very different from Gleason 7. But a tumor at this end of Gleason 6 is really the same thing as a good Gleason 7. But the problem is the pathology report does not convey that information often. And so our reports need to bridge this communication gap. So this is another paper we recently published, making the point that in these borderline Gleason scores, it is not about precision. We need to focus away from precision and more on communication. So to some extent, we have started doing that. We don't report Gleason 7. We stratify it into 3+4 and 4+3. And then we fight about it. We then argue about is it more than 50% pattern 4 or less than 50% pattern 4? But this 50% cutoff, why 50%? The tumor doesn't recognize, the tumor doesn't say that once the amount of pattern 4 is more than 50%, now I can metastasize. No. This 50% is a purely artificial number taken based on convenience. So again, it would be entirely reasonable to treat a bad 3+4 the same way as a good 4+3. But again, if the report only says 3+4 equals 7, there is no way for the surgeon to know whether this is a good 3+4 or a bad 3+4. Which is why now we say we don't report that, we report also the percentage pattern 4. Now this is where we have a major communication problem. And this communication problem is between people like me who write papers and people like the ordinary jobbing general pathologist who reads the papers that I write. And there's often a huge communication gap because they take us too literally. So when we talk about reporting the percentage pattern 4, they go for precision. So they start worrying about, is it 20%, is it 30%? And they spend a long time arguing about to get the precise percentage pattern 4. That's not what it is about. So what you're trying to tell the patient, what you're trying to tell the urologist, is the patient at this end of the spectrum of pattern 4 where he's suitable for surveillance, or is he away from the 3+4 towards the 50% where he is not suitable for surveillance? So this is not about what is the percentage of pattern 4. It's all about the message that you're giving the urologist who has not seen the slide. You are the one who's seen the slide. The urologist hasn't seen the slide, and it's about giving that message to the urologist. So what you've got here is a biological continuum with arbitrary thresholds. You do not require precision. So here's a paper from Sauter's group, so which showed exactly that. So on a radical prostatectomy, they looked at that when you looked at the continuums, so between adjacent groups, the difference in outcome was minuscule. So see whether it is 0% pattern 4 or 5% pattern 4, they behave the same. 40% pattern 4 or 60% pattern 4, there's no difference in outcome. But yet, we worry a lot about getting it exactly right. And then we got, what irritates me and gets me, very passionate and argumentative is pseudoscience. I am all in favor of science. I like science. I believe in science. But I do not like pseudoscience. And unfortunately, there is far too much of it. So we talk about percentage pattern 4. Everybody compare, well, we know what percentage pattern 4 is. The numerator is the amount of pattern 4. And the denominator is, don't know. Is it the area of the prostate containing each pattern? Are we comparing the area occupied by each pattern? Or are we comparing the number of cells of pattern 4 with the total number of tumor cells? Now these three are very, very different. So let me show you an example here. So this is a radical prostatectomy. Here's a single tumor, and this tumor has got different areas. Up here, you've got the usual pattern 3. So you've got these glands with a lot of stroma in between them. Here you've got fused pattern 4 with very little stroma between them. And here you've got a microcystic pattern of prostate cancer, so large lumina with empty spaces with tumor cells around them. So here you've got the denominator would have a lot of benign prostate tissue. Here you would have a lot of tumor cells, and here there would be a lot of tumor area, but fewer cells. So if you compare this and this, in the same area of tumor, there would be a lot more tumor cells in this tumor than in this tumor. So if you've got equal amounts of this and this, there's a lot more tumor cells here. So what are we comparing? Now this is not theoretical, okay? Because first of all, we need to know what we're doing. We are now talking about artificial intelligence. We are talking about machine-based learning. Well, the machine can't do it unless we tell the machine what it is supposed to do. And if we haven't decided what we are trying to do, then what is the machine supposed to do? It can't do it. So we need consensus on what we're doing. But my point at the end of the day is that, okay, let me show you another example here. So that was a radical prostatectomy. Here is a needle core. So here you've got typical pattern 3 with a lot of benign prostate tissue here. Here you've got fused pattern 4. So this is all part of the same core. Now, if I take this and say, what is the grade of the tumor? And I say, this is a lot, the length of this is much more than this. So that would be 3 plus 4 equals 7. But if I go by the number of cells, this one is probably, this is not a good tumor. This is likely to be a bad tumor. So if you go by number of cells, it's 4 plus 3 equals 7. If you go by the area, it is 3 plus 4 equals 7. Which one is right? I don't know. Take your pick. But the point I'm trying to make here is you have to give that, to report such a case as simply as 3 plus 4 equals 7 is misleading the clinician. You have to, in an ordinary case, it's fine to write 3 plus 4 equals 7. But when you got cases which are out of the ordinary, it is your responsibility to convey that information to the clinician. So what we are trying to do with percentage pattern 4 is to give the clinician an idea where the patient is in the spectrum. So let me tell you how I do it. I don't try to figure out what the percentage pattern 4 is. So if I've got a case where I am thinking, is there pattern 4 or no pattern 4? It took me a few minutes to decide whether there's a pattern 4 at all in here. Then that is less than 10% pattern 4. If it's a tumor that I thought that, is it 3 plus 4 or 4 plus 3? And I spent more than a few minutes trying to decide whether it's 3 plus 4 or 4 plus 3. And today I've decided I'm going to call it 3 plus 4. The same case tomorrow I might call it 4 plus 3. But then that is a 40% 3 plus 4. So what I'm trying to tell, so it is not about what the exact percentages is, but I'm telling the clinician that this is at the bad end of 3 plus 4. So when I say 40% pattern 4, I haven't actually calculated the percentage. I am conveying the message that it is at the bad end. Same way, so what I'm saying is 60% pattern 4 means it's not really different from a bad 3 plus 4. And a 90% pattern 4 is when I'm sitting and worrying whether is it a 4 plus 3 or a 4 plus 4. and I've decided to call it 4 plus 3, then that's 90% pattern 4. So try to focus not on trying to calculate the precise percentage, because we don't know what we are comparing, but focus on the message that you're trying to communicate to the clinician where the patient is in the biological spectrum. So this basically informs the clinician where he is in the risk spectrum so that the patient can make an informed decision. So if you understand what I've told you, you will then understand that precision becomes less important if it's communicated properly and interpreted properly. Now that's another responsibility that we have. Clinicians don't look at biopsies. So in our MDT meetings, when we are the cancer board meetings or the tumor board meetings or whatever you call it in your settings, it is our job in these meetings is not to sit there and read the reports. Clinicians are educated. They can read English. They can read my reports. I don't have to read the report to them. They can read it. My job is to interpret the report because they haven't seen the slides. And often they can't understand it because histology is all in the mind. It's a lot of imagination. So let me show you an example where interpretation can be critical. So you got a patient with Gleason pattern 4 plus 3, 80% pattern 4. Is this patient suitable for surveillance? No. He's at least intermediate risk. The NICE guidelines in the UK would suggest that such patients should have a bone scan up front to exclude metastasis, and surveillance is not an option. And that makes every sense. If you got a 20 millimeter of tumor, 80% of which is pattern 4, that's bad news. But what about a 2 millimeter tumor with 80% pattern 4? Is this also bad news? No, but this patient has got it purely sampling. So the idea that you go purely by the bottom line number or the headline figure of 80% pattern 4 and say this is primary pattern 4, bad news. No, you have to correlate it with the amount of tumor that is there. Because if the denominator is very small, then the percentage can be artificially inflated. And that is the pathologist's job to convey that information in the tumor board meetings. Okay, I'm going to Nadeem, Santosh. I'm going to skip a bit if you're okay. Are you okay for time? Because I think I'm worried that I may be going well over time. So if I skip this section on this,
no, sir, don't skip anything. There's no problem about it. Just keep going.
Yeah, you can.
Okay.
Yes, sir, you can keep.
It's too good. Please keep
okay,
going.
but what I don't want is to bombard you with information. There's only so much that you can take. Okay, we will now talk about something else, which again I think is probably an issue for you all too. Santosh, you will have to give me an idea because we can't do a poll. Now, when you have multiple biopsies taken, different pathologists do it differently. In the US, the standard practice is to give a separate Gleason score for each positive core. If you got the cores given separately, you would give a separate score for each. If you get cores given in multiple containers, then you give a separate Gleason score for each container containing tumor. While in the UK, the standard practice is only to give one Gleason score, what we call a global or an overall Gleason score. What's the practice in India, Santosh?
India, sir, we practice if the cores come in separate containers, each core is given a separate score.
Okay, good. Right, so we will discuss that.
Each core is given a separate score.
Yeah, okay. So I think, and that is a hell of a lot of work, I would think. Right? So your reports become very long.
So I have seen certain reports in which every core is given a Gleason grade group and all that also.
Correct.
Given on each core.
Correct. So let's try to understand why we are doing what we are doing. So which score to report? And the reproducibility is important because if you're going to compare data from the US data with India data or UK data or my surgeon survival data with from your surgeon survival data, then we need to be able to compare the Gleason scores. But if we are going to call the same cases, give entirely different Gleason scores, then it's meaningless. But reproducibility should not be at the cost of accuracy. So the important thing is about that patient's treatment, that this patient gets the right information. So which score? So if I've got a case like this, so here you've got tumor, the blue is Gleason pattern 3, the red is pattern 4. So this score, it's all 3 plus 3. This is predominantly 3 with a little bit of 4. This one has only pattern 4. So in the UK, often pathologists would give a global score. So they would consider this whole thing as 1 and report it as 3 plus 4 equals 7. While in the US, they would report separate scores and the urologist would pick up the worst one and treat the patient as 4 plus 4. Now, eventually what matters is not what we report. What we report doesn't matter. What matters is what the urologist does with the report. Which score does he use to treat the patient? That is what matters. Now, in this situation, the worst score is probably correct. Because so what you probably have here is likely to be 2 separate tumors. And this score, which contains only pattern 4, is likely to come from a separate pattern 4 tumor. So the worst score is probably going to be more predictive. Doesn't always have to be the case. You could have an instance where this score just happened to hit only this bit, but less likely. I told you, this is not about getting every case right. It's about probability. And the probability is that it is this scenario rather than this scenario. But what about this scenario? So here we've got the same thing here. You got 3 plus 3, 3 plus 4, but you got a core with a very little amount of tumor. You got only 1 millimeter of tumor, which is only pattern 4. So in this case, again, the global score would be 3 plus 4. The worst score would be 4 plus 4. So in this case, the American experts would suggest reporting it separately and the patient would be treated as 4 plus 4. That would clearly be inappropriate because the worst score is almost certainly going to overestimate the grade. Yeah, go ahead, Santosh.
If I may interrupt, sir. If I may, so in this scenario, the 4 plus 4 may be on the other lobe. So then wouldn't it be like a dominant nodule which is partially hit by this?
It may be.
Because the concept of dominant.
Yeah, but on a biopsy, there is no way for you to know whether this is part of the same tumor or a different tumor. So even when you get on 2 different sides,
I said supposing the first 4, yeah. So first 4 say it's from the right side, and the 5th one is from the left side.
Yeah. We'll come to that. I will deal with your question in the presentation. So your point is a valid one, but it's not a simple one size fits all, whether you report the global score or the worst score. So several studies have concluded that the 2 scores are comparable. So whether you take the worst score or the global score, the patient outcome. So if you take 100 patients or 10,000 patients and you take the worst score and the global score, the outcome is very, very similar, the 2 scores. These reports are very misleading. The reason is that because the worst score and the global score is different in only a minority of cases. So this is not a big thing. Because all cases where there's only 1 co-positive, the global score is equal to the worst score. If the worst score is 3 plus 3, or the worst score is 3 plus 4, the global cannot be anything other than 3 plus 3 and 3 plus 4. So in all these cases, the global score and the worst score would be the same. And these are the common situations. And so any differences between global and worst would be obscured because the majority of cases would be the same. So here's a paper from Kirill Tripkov in Calgary. So where they looked at the case level, global, highest, etc. They had about 2,500 radical prostatectomies. And the global score performed slightly better than the highest score. Nothing much, 60%, 57%. Statistically, it really doesn't matter. But when you look into that data in a little more detail, The global and highest were identical in 92%. And when you focus on the 180 cases where the global and highest were different, the global score was much better. 62% concordance versus 19% concordance compared to the highest score. So which means when you take cohorts of patients, so if you take groups of patients and you only look at the ones where the global score and the worst score is different, then for groups of patients, the global score is better than the highest score. Santosh, I will now come to the point what you made, and your point is very correct. So when you have this sort of situation here, so which one is appropriate? So in this situation, the worst score is appropriate. In this situation, if these are from the same side, the global score is appropriate. If this is from the different side, then it's worth mentioning it separately. But if you got these four are from the same side and this one is from the separate side, it still doesn't make sense to give separate scores for each of these. So what should you do? So one option is simply to pass the buck. So the easy way for the pathologist is say, it's not my problem. I give you the data and you sort it out. So I'll give you all the measurements. I will give you all the scores and the grade groups if you want it, and you choose which one. And what do urologists do? Well, we tried to find out. I think this is again one of these papers where you do a study fully knowing what the results will be. So I knew what the results were going to be before I did this survey. So we asked urologists and oncologists. We gave them scenarios. We gave them this sort of scenario, and about 80% of them would simply ignore anything that's on their dimensions and simply look for the biggest number over here, and treat the patient as 4 + 4 = 8. And that is clearly inappropriate. As I said, we've got this communication gap, and so this is what we wrote an editorial then, saying that it is our responsibility as a pathologist to decide which Gleason score should be assigned. We can't, we can't run away from that responsibility. So we have to take the responsibility. So the pathologist is best placed to identify which is the most appropriate.
Dr. Rajesh, can you mute yourself, please?
Is best placed. Okay, thank you. So essentially, you can't leave it to the urologist. We are best placed to decide which is the most appropriate score for an individual patient. The best score may be the global score, or it may be the worst score. But that you have to decide, not the urologist. And there's another reason for that, because when you try and decide which is the right score for treating this patient, you also have to factor in morphology. And that seems to be totally ignored. None of the review papers, none of the recommendations factor in morphology. So what do I mean by that? So if I've got something like this, so the blue is pattern 3, the red is pattern 4, and the green is cribriform pattern 4. So all of this is polyform pattern 4. So this is very likely to be part of this, which is sampled in this score. So this is likely to be a 3 + 4 = 7 tumor. On the other hand, if all of this is polyform glands and you got a core which has only cribriform, that would suggest that this might be from a different tumor. Suggest, there is no way for being certain. You're looking at probability, but you have to suggest the possibility that there may be a separate higher grade tumor. And again, like Santosh said, you would have to factor in, was it in the same side? Was it from the other side? Was it separate? These days, you would also correlate it with the MRI. Was there an MRI lesion seen? So if these biopsies were from an area where there was no MRI lesion seen, and this was from an area where the MRI lesion was seen, then it's quite likely that this is from a high-grade tumor sampled from the MRI, while these are from the remaining ones is from incidental other smaller tumors elsewhere in the prostate. And that information you have to provide to the clinician. So again, so I think I'd written this one saying that making exactly the same point, essentially, that there is essentially no substitute for judgment. So we are trying to lay down this one-size-fits-all rules and trying to dumb down histopathology, trying to take all responsibility out, trying to take all judgment out of histopathology. Sorry, we are making, how do I put this? We are doctors. We are making technical staff out of doctors. We are, as I tell my trainees, if you want to be treated like a doctor, the first thing you've got to do is to start thinking like a doctor and behaving like a doctor. If you don't think like a doctor, you don't behave like a doctor, you don't report like a doctor, you don't show any interest in the clinical management of the patient, then don't expect to be treated like a doctor. And I think to some extent, pathologists, I think, in my opinion, maybe I'm getting old and grumpy, but I think pathologists are tending to run away from the responsibility. And that worries me, because that is not good medicine. The counter argument that I often get is, Murali, if you let pathologists use their judgment, you will have no reproducibility. It will be like the Wild West. Pathologists already use their judgment to decide whether it is prostate cancer or not prostate cancer. So when we decide whether to call it highly suspicious or to call it definite cancer, that's a judgment call. When I decide whether is there pattern 3 or pattern 4 or pattern 5, that is a judgment call. So if I'm using judgment for all of that to decide whether there is this fusion or are these tangentially cut pattern 3 glands, that is a judgment call. So I'm allowing the pathologist to use the judgment for all of that, but to decide which Gleason score is appropriate for this patient, you can't use your judgment for that. To me, that doesn't make any sense at all. I think pathologists have to be, yes, the expert's duty is to provide guidance, to guide the general pathologist how to make that decision. But you have to let them do it. So the ISOP recommendations is that the individual or container Gleason scores are mandatory and a bottom line case level Gleason score is optional. Now, as somebody asked me earlier, am I an ISOP person or a GUPS person? I would say neither. I'm on the side of what I think science is. In my opinion, it's the other way around. If you want to give the individual and container Gleason scores, feel free to waste your time. But you have to give a case level Gleason score because it is your responsibility. Now, you may have 2 case level Gleason scores. So you might well say that I think there is a 3+3 tumor here and possibly a separate 4+4 tumor, or a 3+3 and a 3+4 tumor. That's fine. Or when you get a targeted course from an MRI targeted course, that the targeted co-biopsy is showing a different score from the non-targeted biopsy. But that has to be given by you. But you have to convey that information. Just blindly giving a set of scores and letting the urologist choose, like from a laundry list, that is not pathology. That is not medicine. That may be histopathology. Again, I come back to this one here. The same case here. So is this 3+4 equals 7 by area or 4+3 equals 7 by cells? I would argue neither. It's probably 2 separate tumors. So in this case, actually, this particular case was an MRI targeted lesion. It was an anterior lesion on the MRI. And it's quite likely that what you're seeing here on the edge of this biopsy is the lesion that they saw on MRI. And this bit is a separate tumor altogether. So to report this case as 3+4 equals 7 would be absolutely misleading. So here you got, so when we talked about whether to give the global score or the worst score, here I've got a single score in which I've got 2 different scores. So it is important to say even on this one score that is positive, there's a possibility that there is a separate high-grade tumor. And how do you manage this? You may want to manage it as limited amount of pattern 4+4, but if you have seen on the MRI, like in this case, you have seen a large tumor on MR, then this is a large high-grade tumor. It's not a large 3+4 tumor. Nadim, are you sure I'll continue with this introductory carcinoma? Santosh?
Yes, sir. Yes, yes, yes. Yes, sir.
Okay.
Please go ahead.
Okay. Because this is again an area which is, I think this one is actually going to be very, very important for Indian pathologists. Because, you know, all this thing about the Gleason score, the surveillance versus non-surveillance is not a scenario that you all will face that often, because most of your patients come with advanced cancer. But intraductal carcinoma of the prostate is, you're going to see a lot of it because these are patients with advanced cancer. Yeah, again, if you would mute your mics, please. So if you look at the two guidelines from GUPS and ISUP, intraductal carcinoma of the prostate, ISUP recommends that it should be included in the Gleason score. I chaired the working group, so I guess I had a say in that. So you can see which side I belong to and what side of the argument I favor, while GUPS favors that it should be excluded and reported separately. Now, why is this important? So here you've got a case, morphologically, that is Gleason pattern 3, and that is cribriform pattern 4. I suspect 90% of experts would have reported this in 30 seconds as 4 plus 3 equals 7, cribriform pattern 4. But some pathologists decided to do immunohistochemistry. And once you do immunohistochemistry, then all these cribriform glands have got basal cells. And now you're in trouble because cancer doesn't have basal cells. So this is no longer invasive cancer. So that's all intraductal carcinoma. So this is tumor within benign glands. So now, if you're following the ISUP guidelines, you would report this by morphology as 4 plus 3 equals 7. While if you're following the GUPS guidelines, you would report this as 3 plus 3 equals 6 with IDCP. So there's a huge difference in the Gleason score. So to understand this, we need to first understand a bit about what we mean by intraductal carcinoma. So that is the official definition of intraductal carcinoma of the prostate. It's where you got these pre-existing ducts which are dilated, which are filled with these atypical neoplastic cells. So like this one here, morphologically, it looks like Gleason pattern 4, but you do the immuno, they've all got basal cells. So these are neoplastic cells within pre-existing benign glands with basal cells. Similarly, you can get ones with comedonecrosis. So morphologically, that is comedonecrosis pattern 5. If you do immunohistochemistry, then that is not comedonecrosis pattern 5. That is intraductal carcinoma. Now, everybody agrees that in the vast majority of cases, that when you see intraductal carcinoma, this is bad, nasty, very aggressive, high-grade cancer, which is invading back into the benign. So it's like retrograde invasion into the benign pre-existing ducts. And only rarely is it a pre-invasive lesion where there is no invasive component at all, and all you have is this. And that is a very rare scenario. That there is consensus. Both GUPS and ISUP both agree. One point I think that is important to mention is there is confusion even among pathologists. Clinicians get confused between ductal and intraductal. So often when we talk about intraductal carcinoma, which is an aggressive form of prostate cancer, it gets confused with ductal carcinoma, which is an aggressive form of prostate cancer. Now those two are very different things. Ductal carcinoma is a variant type. It's a subtype of prostate carcinoma, and this word ductal refers to the subtype. It's a phenotype of the tumor. On the other hand, when we're talking about intraductal, the ductal doesn't refer to the tumor type, it refers to the tumor location, that the tumor is within the ducts. So it's intraductal. So the key question here is, how do you report IDCP? It's morphologically high grade, should it be graded? So it's important to realize that biologically, there may be two different diseases. There may be a precursor lesion, which is a very rare situation, and the more common, it's IDCP invasive, which is basically the growth pattern of invasive carcinoma. There is consensus between GUPS and ISUP that pure IDCP should not be graded. There is consensus between GUPS and ISUP that IDCP is bad news. Both GUPS and ISUP agree that patients with IDCP should not have surveillance. So if once you have IDCP, surveillance is not a good idea. Both of them recommend that the presence of IDCP should be commented upon. So the point I'm trying to make here is, when you read these papers, you get the impression, God, GUPS and ISUP are entirely at odds. Actually, they're not. They're both saying the same thing. So what we are arguing about, what GUPS and ISUP are disagreeing, is not about the information. We both agree on the information, but we are all talking about the communication as to how that information should be conveyed. ISUP believes that it is simple, it is simpler and scientifically correct to include it in the Gleason score, while GUPS believes that that in rare cases you might overgrade it, and so it should be given separately. So this is what the difference is. We talked about this. The problem here is for the clinician. Now imagine you are the urologist. You've got a pathology report there in front of you. The biopsy report will say Gleason score 3 plus 4 equals 7, and with a comment that IDCP is present. Now, how is a urologist supposed to know whether this has been reported using the ISUP guidelines and the IDCP has already been incorporated into the Gleason score, or is he using the GUPS guidelines and where the IDCP is separate? So there is no way for the urologist to know that. And if so, there is a risk of them double counting it. So there is 3 plus 4 equals 7 and there's IDCP. So this is really bad news. But this isn't, because that IDCP has already been included in the Gleason score. If it is the ISUP one, rules have been followed, but not the GUPS. So you can see the amount of confusion it can cause, even though we are providing the same information, because we are not communicating it the same way, we can cause a huge amount of confusion. I'm not going to go into the details of this. For those who want to know the details of the arguments against and in favor, I would recommend this article. I'm pretty proud of this article. So of all the papers that I have written, I think I'm very proud of this one, is because every paper we write, we have our biases. I have to put my hand up and say, I have my own biases. So I do tend when I give arguments, it's inevitable that I will give more arguments on the one that I favor and less probably either more. I tried to be fair, but at least subconsciously there's likely to be a bias. So what we did here was a head-to-head debate with Jonathan Epstein. We wrote the introduction and the discussion together, but the two in-between bits, the arguments why it should be graded and why it should not be graded, were written entirely independently by Jonathan Epstein and myself. So here you get so this is the views, which are you get the complete picture. So I would go to this and read all the arguments in favor and against. Now, the only point I would make, my argument for this, is that everything that I have told you so far, I hope I have convinced you that precision is impossible. You cannot get every case perfectly right because you got the sampling error of the biopsy. So what we are trying to do is to get the most of the cases right. So the GUPS guidelines are based on rare scenarios, the 3 plus 3 with IDCP, which is a rare scenario, and where you get that 3 plus 3 with IDCP is pure. And to me, the guidelines should not be based on rare scenarios. Guidelines should be based on the common scenarios. And let's look at that again. So, the rationale for not grading IDCP, the GUPS recommendation, was largely based on this paper. So this is the Carney and Epstein paper, which looked at 3 + 3 = 6 with intraductal carcinoma. There were about 16 patients who had radical prostatectomy. In 3 of these patients, radical prostatectomy. So these were patients with 3 + 3 = 6 and intraductal carcinoma in the biopsy, but the radical prostatectomy showed only 3 + 3 = 6. There was no high pattern 4 or higher tumor in the radical prostatectomy. So the argument is that these patients had an unnecessary radical prostatectomy because if intraductal carcinoma was included in the Gleason score, they would have had an unnecessary radical prostatectomy. My argument is, first of all, you cannot diagnose IDCP without immunohistochemistry. So here is this case. That looks like invasive carcinoma. I mean, 9 times out of 10, we would report this as intraductal carcinoma without doing any immunohistochemistry. But once I do the immunohistochemistry, some of them have basal cells, some of them don't. Now that one has got a basal cell there, that one has got there, but there are larger parts of it which don't. And this gland which doesn't have it is like this one here. You got basal cells here, but this is all plane of section. So it's your blind man and the elephant. The ones that are negative could still be IDCP, where the basal cells are not seen in the plane of section. So here's another example here. So you've got basal cells here, but the glands without basal cells and the glands with basal cells look identical. So is this invasive carcinoma with IDCP, or is this all IDCP where some glands have basal cells seen in the plane of sections and some don't? There is no way. So the point I'm making here is that we can diagnose IDCP reliably with immunohistochemistry. What I mean by that is, if I find basal cells, yes, I can say that that is IDCP. But I cannot diagnose invasive with IDCP, absence of basal cells. Because even IDCP may not have basal cells depending on the plane of section. And then all the data that is there, all the published data was based on morphology. There is no data out there. And incorporating IDCP, so the argument is about the Carney and Epstein paper, which said, what about those 3 patients, those 21% of patients, which is just 3 patients who were overgraded if you included it into the IDCP, if you included the IDCP into the Gleason score. We need to look at this paper in more detail. So a superficial look at this says that 20% of the patients would have been overtreated. But all these patients who had only 3 + 3 in the radical, had the radical prostatectomy was only partially submitted. Sorry, is my voice breaking there?
It's better, Dr.
Yeah. Okay.
Now it's better.
Yeah. Okay. Yeah, I think
it's fine.
Yeah, I think sometimes also with the internet, I'm afraid.
Please check at the receiver's end. It's fine at our end.
Okay.
Absolutely.
Okay. So the internet, I'm afraid, can cause problems. Yep. Yeah. Okay. So, but if you look at these 3 cases where you had 3 + 3 with intraductal on the biopsy and only 3 + 3 on the prostatectomy, all of these were only partially embedded. So if it's been partially embedded, how can you exclude the possibility of unsampled high-grade tumor? You can't. And moreover, if you look at those 3 cases, one of them had extra prostatic extension. The other one was mixed acina and ductal. And the third one developed biochemical recurrence. That's not good prognosis 3 + 3 tumor. So so even those tumors, which are supposed to be good prognosis, 3 + 3, they were pathologically and in one case clinically bad outcome tumors. And then you look at all the other tumors. It's only 16 patients had a radical prostatectomy. But if you look at the whole cohort of patients of 3 + 3 with intraductal carcinoma, 7% of them had metastatic disease at presentation.
In the prostatectomy, 29% were 4 plus 3 equals 7. 28% had seminal vesicle invasion. 20% disease progression in 3 years after radical prostatectomy. 13% developed metastasis. 7% died of the disease. This outcome is not that of 3 plus 3. So 3 plus 3 with intraductal, if you call it 3 plus 3 equals 6 and put intraductal separately and treat those patients like 3 plus 3 or in any way downgrade them, they do not behave like 3 plus 3. They behave like aggressive tumors. So it's much more. So my opinion is that, again, read the debate so that you get a full picture of both views. So my opinion is that there is no evidence to support inclusion or exclusion of IDCP invasion or IDCP invasive because there is no outcome data based on either. IDCP cannot be reliably identified by morphology. IDCP cannot be reliably excluded by morphology. There is consensus that IDCP is an adverse prognostic factor. It is simpler and more pragmatic to simply include the IDCP into the Gleason score rather than to cater to rare scenarios and risk messing up the more common situations. Okay, we'll move on very quickly. I'll take questions at the end for those who have the stamina. We'll talk about this new grading system for prostate cancer. So we have this new grading system for prostate cancer. As you can see, it got a lot of publicity. The AUA News, Renal and Urology News, Healthy Living, and very significantly, Financial Review. I think that's a very topical one. It's a lot of things that we do have financial implications. Our diagnosis of prostate cancer can ruin people financially. Okay, so the new grading system for prostate cancer had a lot of publicity. So what is this? So essentially what we had was grade groups 1 to 5. 1 is Gleason score 2 to 6. 3 plus 4 equals 7 is grade group 2. 4 plus 3 equals 7 is 3. 8 is 4. 9, 10 is 5. So the first point is there is no new grading system for prostate cancer. This is not a new grading system. It's only a different way of grouping the grades and scores. We have always, so when Vishal asked me right at the beginning, do we need something simpler rather than all this slicing and dicing? In practice, pathologists slice and dice, and the urologists then lump them together. So the urologists have always lumped the scores. So they were lumped into 2 to 4, 5 to 7, 8 to 10, 2 to 6, 7, 8 to 10, so on and so forth. All of these have their logics. So there were reasons to lump these. But the point I'm making here is that this sort of grouping is not unique. There's nothing new about it. And more important, there is no additional information in the path report that by giving the grade group in your report, you are not providing any additional information. So if I don't provide the grade group and I provide only this, the clinician can extrapolate the grade groups. You don't need that. So in the past, I only did this. I only gave the one on the right, the Gleason scores, and the clinician then put these into groups and said low, intermediate, high risk. So the clinician put them into 1, 2, 3. The only thing is he didn't give it a number, he put them into groups. So this is not a new grading system. In fact, when we give the grade groups, we are giving less information than the Gleason score. Because grade group 5 may be either 4 plus 5, 5 plus 4, or 5 plus 5. So by if we give only the grade group without the Gleason score, we would be hiding information. So nobody recommends, including GUPS, everybody recommends that the grade group should be reported in conjunction with the Gleason score. And then you got the uncertainty. What do you do with a minor grades? So when you got less than 5% pattern 5, should that be included into the grade group or not? That's another controversy. So grade groups is nothing new, doesn't provide any additional clinical information, but clinically could still be useful. So why is it clinically still useful is because in different countries, especially in the West, and I suspect in big cities like in India, where you got your corporate hospital and you got where patients go and read the reports, that's where the grade group might matter. So grade group is basically meant for is when the patient reads the report, he sees 3 plus 3 equals 6. What does he do next? Google. When he Googles, he sees that Gleason scores range from 2 to 10. He's got a Gleason score of 6. Where is 6? In between. So he thinks that he's got an intermediate grade disease. But actually what he got is a minimum Gleason score that we give is Gleason 6. So in order so that the patient doesn't panic by seeing when he sees Gleason score of 6, if you put in the brackets grade group 1, then that makes it easier. So what is unique about this, about the new grade group system is not the grouping. The only thing that is novel, and that was something that Jonathan Epstein proposed, and I think he deserves credit for that, is for giving these numbers, to put their numbers as 1, 2, 3, 4, 5, rather than simply putting a group. Now, the reason for that is that bridged the communication gap between pathologists and patients. So now when the patient reads it, he sees at the bottom grade group 1, and since 1 is the lowest number, that is reassuring. So this is important in 2 situations. One, if you've got patients who are reading the pathology report. 2, if you've got clinicians who can't be bothered to explain the pathology reports. So if you've got patients who are being properly advised by clinicians, then the grade group really doesn't add there's no benefit in adding the grade group. The grade group is useful if you've got patients who are trying to interpret the reports independently. But still, I think this is very interesting. To my knowledge, this is the first time ever that the pathology reporting practice has been changed to directly address a change in patients' practice. It's because patients go on the internet, patients Google, we changed. Well done, uropathologists. I think we all uropathologists and should, ISOP, GUPS, Dr. Epstein, everybody should pat themselves on the back, because for the first time we have done something where we have done it like doctors. We have put the patients first and not just the science. So to summarize what I've said, precision of Gleason grading is simply not possible. There's nothing wrong with us. It is not possible. It's unattainable because of sampling error. Precision in radical prostatectomies is not necessary because PSA monitoring is better. Gleason grading, in my opinion, is seriously overcomplicated, and communication is the key. And if you have the communication right, then we don't have to worry about too much about all these borderline ones. Well, I'll give you a little bit of a plug for next week. Next week, I'm going to talk about grading. I'm going to talk about bladder cancer grading. Here, it's interesting. With Gleason grading, I think we have overcomplicated it. With bladder cancer grading, I think we have seriously oversimplified it. And by oversimplifying it, I think there are serious clinical implications. I think we've got patients being, there's a serious risk, in my opinion, patients are being overtreated because we have oversimplified bladder cancer grading. And I will explain that next week. And I will present to you the similar arguments and explain how, again, whether this is grade 1, grade 2, grade 3, or whether it's grade 2 or grade 3, or it is low grade or high grade, the precision is not that important. It's not important to get it exactly right, whether it's low grade or high grade, provided you can communicate properly. Communication is what matters. Finally, at the end of it, I think since this is going to be put up on YouTube, I'll put up a list of references which you can then read these papers. So essentially, they are telling you my views in more detail and which you can read at your own leisure. Thank you for your attention and your stamina. I'm happy to take any questions.
Thank you, sir. Thank you. Thank you so much for that wonderful, thought-provoking lecture on prostate cancer. So I am sure there are many questions and many things in people's mind regarding prostate cancer grading, scoring, and why it happens, why there is difference between the systems, why there is so much confusion. The issue is always remains that if we are confused, then how do we convey to clinicians? So I think that's what Dr. Bindu has asked. She is it if we have ISTP and GUPS, will it not be confusing for clinicians? That's the first question that he has asked.
Yeah, correct. I think I totally agree. I don't think it's just confusing for clinicians. It's impossible for clinicians. So what I've been trying hard to do is to try and get ISOP and GUPS together, to try and get both groups into one room, to have a consensus conference together, try to come up with an agreement together. In practice, because the point here is that we're giving the same information. So we are not disagreeing. There is no fundamental difference between GUPS and ISOP. The differences are largely about how to communicate. So what do you do in clinical practice? I think it's important for you to communicate. So long as you communicate in your report where it is in the spectrum. So have you included the less than 5% pattern 5 in the Gleason score or not? So if you have included it, you can't report it simply as 3 plus 5 equals 8. You need to say that this is less than 5% pattern 5 which has been included. So then it makes it clear whether it has or hasn't. The other side, as I said, on radical prostatectomies, it's clinically probably not that important, because eventually it's all PSA monitoring that matters, the borderline ones, and adjuvant therapy. So I would not, personally, in my own practice, I would report something as pattern 5, I would want the most obvious pattern 5. Anything that is borderline, where I've got the slightest doubt whether it's a pattern 5 or no pattern 5. If I've got the slightest doubt whether it is less than 5%, I don't include it. I always err on that side, because what's going to happen if I don't call it pattern 5? The patient gets PSA monitoring, and if the PSA starts rising, he gets treated. If you report it, potentially if you're talking about adjuvant therapy, then a patient gets unnecessary adjuvant therapy. You're talking about radiotherapy side effects, colitis. You can cause cancers. There are significant harm that you can do to patients by overgrading radical prostatectomies. So I think yes. So I think the point I hope I've been able to convey is, so long as you communicate it properly, we don't worry too much about these things. Yeah. Go ahead.
Yes, sir. A similar thing. Dr. Soni has asked: is it really? It's not easy to find grade 5 pattern less than 5%, and is it really worth it? Finding that is the whole exercise worth it? Probably you have already answered that. So again, so do you really struggle
let me
look at the find that less than 5% tumor?
Correct. Okay, Santosh, let me explain this a little bit more. Okay, endometrial cancer, right? You've got again you got the 50%, and I think it's again 5%, isn't it? That when you grade 1, grade 2, grade 3, as to how much solid areas you include.
Yes.
No expert pathologist really tries to. Does anybody really calculate what is 5%? No. Listen, two things here. One, I explained to you earlier. This business about percentage. It's about what are you comparing? Number of cells, area, whatever. We don't know. Okay. But even other than that, these are on different slides. So you are mentally trying to compute. So if everything is on one single slide in one single image, and you're trying to calculate the percentage, when I showed you, that is hard enough. But when you got it in 20 different slides, and you're trying to decide what is the percentage of pattern 4 or percentage of pattern 5, we are fooling ourselves. Okay, that is pure pseudoscience. So what do we mean by less than 5% pattern 5? Is not really 5%. And why 5%? Why not 3%? Why not 1%? Why not 10%? What we mean is, if you had to really search for it, if you found a little bit of pattern 5 after a lot of searching, that is not relevant. If you got pattern 5 that was easily found, that you got that you could find, there's it's not something that you had to go searching for, then that is more than 5% pattern 5. There is, to my knowledge, I do not know of a single expert uropathologist who spends time on a radical prostatectomy or even on a biopsy actually trying to calculate the percentages of pattern 4 and pattern 5. It's simply not, it can't be done. So what all of us are, we know that what we are doing is communication.
Yes. The next question is
Santosh,
from Dr. Pulkit Rastogi. He has, Dr. Pulkit has asked, are there automated algorithms and AI to help general pathologists? Wouldn't it be better that all GUPS and ISUP get together and get some software and artificial intelligence? Is anything being used in the UK, sir? Artificial intelligence for Gleason?
No. There are research. There's a couple of papers recently published on artificial intelligence. But again, this is where we are fooling ourselves. So we don't need artificial intelligence, provided we use our natural intelligence intelligently. The reason we are going for artificial intelligence is because we are refusing to use our natural intelligence. So what are we, as I keep saying, why do we need artificial intelligence? We've got a biological continuum here. You got a morphological continuum. So when you go use artificial intelligence, you are going to have to tell that, it is GIGO, isn't it? Garbage in, garbage out. So what you get from the machine is as good as what you put into the machine. Whatever algorithms you put in the machine, it will come out. So if I create a machine, the best it can do is what I can do. It can't do better than I can do because I'm setting the rules for it, right? But if those rules are going to change on Monday and Tuesday, then what does it mean? So this is my point. So provided we understand what we are trying to do, provided we communicate that properly, provided we explain that properly to the clinicians, and provided the clinicians try to understand what they're trying to do, then we don't need artificial intelligence. But if we don't have all of this, yes, you can have artificial, but it's not going to make it any better than what it is now. Yes, it will give you so-called more reproducible data, but not more accurate data, right? So yes, it's like measuring something, right? So if I want to measure the amount of tumor in a biopsy, if I have a machine, it will measure that tumor more accurately. But it doesn't matter. The sampling error of the biopsy is huge. So whether it is 2 millimeter tumor or 2.5 millimeter tumor or 2.8 millimeter tumor, does it matter? No. Yeah, so I think, again, I come back to, as pathologists, we have to be doctors. Yeah, Santosh.
Just a couple of more questions. Vishal asks, how do you do the global scoring? And Mahesha wants to ask whether when you have tumor at two ends of the core, how do you give the percentage of the core involved? Is it like Epstein's method of 100% or do you factor in that percentage? So, so I'll take Vishal's one first. Sorry, just repeat that. I'm sorry, I'm getting old. I was just tired. How do you give a global? So SH, correct. So I do what we do in my practice. Every case gets a global score. Okay, so we give a global score. Now, in many cases, the global score and the worst score is the same. So all the patient gets is one global score, and that's it. In the rare cases where I think there is a separate tumor, I would give a global score, and then I would add a comment. However, the biopsy from the right apex shows only Gleason pattern 4, shows 6 millimeter of pure pattern 4, suggesting the possibility of a separate 4+4 tumor. Right? So rather than giving each core, positive core, a separate one, I would give. So if I've got like the same thing happens with, if I've got a lot of biopsies, I've got 3+4. Okay? And on one biopsy, there's a bit more 4 than 3. If that all looks, the pattern 4 all looks the same, I just report it as 3+4 equals 7. It doesn't make any sense just because that one core happened to have more pattern 4 sample than pattern 3 to put that patient in a different grade group is, to me, not science. Vishal, does that answer your question, Vishal?
Yes, sir. Yes, sir.
Yeah. Okay. So that's my approach. So essentially, as I come back, it's about communication. The other question about the extent, exactly the same thing. It's about communication. So what do I do when I've got tumor at both ends? Like Epstein. See, the problem you have here is what we do not know is whether this is one single tumor, which is coming in and out of our core, or are they two separate tumors, right? Now, I look at two things. Again, I look at the morphology of the tumor. If the morphology is identical, then even if the cores are further apart, if those foci are further apart, I will consider them as one tumor. If the morphology looks different, then I would suggest a possibility of two different tumors. Right? Now, when I give the millimeters, so if I think it's all one single tumor, I would say, say it's a 15 millimeter core with both ends. I would give 15 millimeter and within brackets discontinuous. Okay, let me give you a slightly different example because I think it will be more illustrative. Suppose I got an 8 millimeter tumor, and at both ends of the tumor, I got a little bit of both ends of the core. I've got a little bit of tumor. So I would say 8 millimeter within brackets discontinuous. And then on another core, I've got 9 millimeter of tumor. Then that's all my report has. So I shall have all the lengths, and this one will have 8 millimeter brackets discontinuous. But suppose all the other cores, the maximum length is less than 8 millimeter. Then I would write a sentence at the bottom saying that I would give these measurements and say the maximum individual tumor length is 3 millimeter. And to say that because that discontinuous is maybe overestimating the tumor length. So it's again, I come back to the same thing. It's all about conveying that information to the clinician. Is that okay?
One last question.
Yeah. Thanks.
Yes, that's okay. One last question. A couple of people, more than 2-3 people have asked, do you do basal markers in all cases which you think are pattern 4, cribriform or something to rule out IDCP?
What do you think? No, obviously not. They said because I follow again, as I said, because I follow the isopline. Right, so when we had the discussion in Nice, at the consensus conference in Nice, where I presented the arguments for IDCP grading, the whole idea of including IDCP in the score is you don't need to do immuno. That I do my Gleason grading based on morphology. If it looks like pattern 4, it's pattern 4, right? So I think this is my point. There are no publications showing that IDCP with if I've got cribriform with basal cells and cribriform without basal cells behave differently. Where is the publications for that? There are none. There are so I think there is the Dutch and Canadian group where they have lumped together with cribriform and IDCP together. That makes sense. So then it becomes exactly like cribriform. So like when I report 3+4 equals 7, within brackets, cribriform present. So what I mean is cribriform has already been added into that 3+4 equals 7. This is not additional cribriform. And that's what GUPS also would do. I treat IDCP exactly the same way. Right? So in practice, the only time I would report IDCP is two situations I do immuno. One situation is purely for education purposes. So either with my trainee or for my teaching purposes, I want a slide. In my report, I don't mention IDCP. I might, because of the ISO guidelines, I might mention the presence of IDCP, but IDCP is included in the Gleason score. But it's very unusual for me to do the immuno. I don't think there is any need to do immunohistochemistry for purpose of Gleason grading, in my opinion. As I said, you will get different opinions from different experts. But all I can say is, show me the paper that says, show me the evidence that says that the cases where you showed basal cells, those behave differently. So if you got commital necrosis with and without basal cells, now, particularly in a biopsy, if you got commital necrosis with and without, now let me tell you another story here, which I think is important. So we had this thing about commital necrosis, IDCP. There were two papers published, one from Sloan Kettering, Samson Fine was the main author, and the other from Henry Ford, with Sean Williamson as the main author. So both of them showed that the majority of cases of computer necrosis, if you go and do immunohistochemistry, you will find basal cells. So both of them said that most cases of what we are calling computer necrosis pattern 5 is actually IDCP. But what is interesting is those two experts interpreted IDCP very differently, the reporting. So if you had a focus where some of the computer necrosis glands had basal cells and some did not have basal cells, in Samson Fine's paper, he would report that as IDCP and invasive. So the ones that were positive for basal cells was IDCP, the ones that were negative was invasive. In Sean's paper, the ones that he took the whole focus together and said it's all IDCP, some with and some without. Now, who is right and who is wrong? Impossible to say. In some cases, Sean would be right. In some cases, Samson would be right. So there is no. So the point I'm trying to make here is we can't be precise. And if we can't be precise, I think it is more honest for us to say we can't be, and we don't need to be. Because there is no evidence that the outcome of computer necrosis with basal cells is different from the outcome of computer necrosis without basal cells. There is no publication. There is no evidence whatsoever.
Great, sir. Yeah, agree, sir. I think it's been 2 hours, sir. You've been continuously speaking for 2 hours. I think we will
Santosh, let me just make one point again. I think it's a very important point for me to make here. Right? I've given you my arguments in favor, and obviously I'm very passionate. I believe strongly that these views. But because I believe strongly something doesn't make it right. Just because somebody else believes strongly otherwise, it doesn't make the other thing either right. So you've got to balance that. So I give you my arguments, read the various arguments, and then you can decide as to which is the right one or which one. And a lot of these is whether the glass is half full or half empty. Yep. So sorry. Go ahead.
One thing.
Go ahead. Yeah. Go ahead.
Want to say something, Sandhya madam? So one thing what is definitely we all agree on IDCP in most cases is a tumor, is a cancer which is going into the ducts, which is following into the ducts or branching into the ducts or invading the ducts. So I would totally agree with you that I think IDCP should be graded. So that is ISOP is probably right in grading introductional compared to ducts.
I almost agree with you.
People also agree to the fact that it's a cancer which is invading the ducts, which is going into the ducts, and then why not grade it actually?
Yeah, Santosh, when you say that your ISOP is probably correct, I partly agree with you. I only disagree with the word probably.
Yeah.
In my opinion,
I think
obviously,
yes. Yeah. No, I think that's perfectly fine. If we all agree on the fact that it's a cancer which is going into the duct, then if it's already a cancer, then it's running through, which is running into the ducts, then we should probably grade it.
Grade it. Now, there's the other side of it, everybody agrees, including the experts, including the experts on the other side, including CUPS experts, that IDCP should be included in tumor extent. So when it comes to tumor extent, IDCP is included. Now, tumor extent and tumor grade are both prognostic factors. So why do you include it in one but not the other? So my view, which I've been pushing on this obviously for many years, is that we should not overcomplicate. It is okay to complicate things if it is clinically relevant and if it can be done. But if we cannot do it and it is not clinically relevant, then it's a waste of time.
Yes, sir. Dr. Nadeem, sir.
Yeah. Yes.
I think your final words on this today's
my final words is this, that if there was a way in Google Meet to give a standing ovation, we would have. Excellent presentation.
I think we all would agree.
And excellent stamina. You maintained the same tempo, 2 hours, 20 minutes on it.
I told you this is going to go longer than I had expected.
And I have no issues about that, because this is the way, everybody will learn. Time-bound teaching is not possible. So there is Another thing I would like to request you, sir, is that there are questions. Hello.
Yeah,
Hello.
Can you hear me?
Yeah, I can hear you. Yeah.
There are questions which I have copied from the chat as well as from the YouTube.
Yeah.
And we have a Telegram group in which everybody is present. I don't know whether you are there, sir. If you are not, I will give you the link.
Yeah. Send me the link. I will. Yeah.
I will send you the link, and I will post all the questions which have been put in the chat here as well as on the YouTube, and you can answer them then there at length, and people can ask you there, because I think there's no end to this. This will just go on and on. And I would like to thank everybody who has participated and all those people on the YouTube. And then there are people from Europe, America, Far East, Middle East who would be seeing the video late night, and they would be also having some questions there as well. And at the end, I would like to thank Murali sir for giving this wonderful lecture and an extraordinary insight into prostate. And finally, would like to thank Santosh for consenting to moderate this thing. Thank you, Santosh, very much.
Pleasure. The pleasure is all mine, sir.
And my last,
I think Dr.
last word of
Madam wants to say something. Her.
Okay, Nandita, please.
For me, the standing ovation is there. Honestly speaking, it's just amazing. Just amazing.
I think it's my pleasure. I mean, I'm very grateful to you, Dr. Nadeem, for the invitation, and I enjoyed talking to you. It's not, as I said, there's no right and wrong. It's often a glass half full and half empty. But it's very important that we talk to each other and discuss and not fight.
And finally, at the end, I would like to thank the internet for providing us uninterrupted service. Thank you so much.
Thank you, sir.
Thank you all.
Take care. Bye-bye. Bye-bye, everybody.
Thank you. Thank you and good night. Thank you very much. Thank you so much, sir. Thank you. Good night.
Yep.